It's a real pleasure to be here, see all everyone here. This is by far the largest audience I have seen in one of our annual conferences. What I've been asked to talk to you today is about how do we do the treatment these days, because these were the questions, these were the things that members and supporters of Epilepsy Society have asked. But when I got a briefing to what I should talk about, there were about 15 points. And I said, God, it will take me probably an hour for each one of these points to discuss them properly. And I've just been given 30 minutes. So rather than spend 2 minutes on each one of the 15 briefing points that I was given, I decided to tell you what I feel and where we are nowadays with antiepileptic drug treatment. Why is it so frustrating for people, sitting on the other side of the desk, but also for us sitting on the side? Because, I like to think myself as a clinician, as a scientist, that I can be doing precise medicine like Sanjay, like we heard from Helen, but I'm afraid that often I shoot in the dark. Most of the time I shoot in the dark and hope it works. No different from many shamans out there. And before I retire, I really want to see proper, precise, tailor medicine to the person. So we don't have to go through all the frustrations on both sides of the desk. So I'm going to start just reminding you what Sanjay said and we heard from Helen. Epilepsy is not just having seizures. Epilepsy is actually something that results in a number of problems for a number of people. Social disadvantage, it actually disability, and one subject that is becoming more and more in the forefront, premature mortality. Epilepsy, particularly uncontrolled epilepsy, takes a number of years of people's life expectancy. So that's really one big issue for us when we try to treat, to manage, to improve the life of people with epilepsy. It impacts on many domains of people's life, from education, employment. People often end up being dependent, and that has implications in family life, because often people will have to become carers for their loved one that has epilepsy. And it affects general health, because epilepsy often goes with other medical conditions. It's not just the seizures. It comes with a baggage. So it's very important that we realize that stopping seizures is not everything. And I think that treating epilepsy is much more than antiepileptic drugs. And we need to really try and provide and get a person a holistic approach, as we heard earlier. Now, I know that we heard a lot about surgery, we heard a lot about ketogenic diet, other therapies, but the truth of the matter is that antiepileptic drugs are still the mainstay of treatment. They may have a lot of problems, they might be not perfect, they have side effects, we often don't know where and how we should use it, and there might be many other drugs that could help a few people that are not currently used for epilepsy. But if we look what we have, 95% of people with epilepsy that require intervention treatment, it is the drugs that we have. And therefore, the drugs are still an important part of the current treatment. I suspect they will still be part of the treatment in a few years down the line, when we will be able to have done what we want with the delivery of genomic scanning, developing and tailored treatment for the person, precise treatment. So what are our goals when we treat someone with epilepsy with an antiepileptic drug? And why I'm saying this? Well, if we looked at antiepileptic drugs, they are used for a number of other things. Indeed, in some countries, more than half of the prescriptions for so-called antiepileptic drugs, they are used for pain, they are used for psychiatric issues, they are used for other problems. So antiepileptic drugs are used in other conditions. This is probably telling us something, which, when we have a better understanding of all the mode of action, what is behind epilepsy and the comorbidities, we will be able to understand what this is. But when we treat someone for epilepsy, I think that the first and most important thing is, yes, we need to try and give this person seizure freedom. Many of my colleagues they have this mindset that a 50% seizure reduction is a good outcome. Well, that might be a good outcome for the drug regulatory agencies like the FDA or the European Medicine Agency, because when you do a controlled trial to see if the drug has some place, you have to have a pragmatic outcome. So this 50% seizure outcome comes from these trials. But it's not really something that will make a difference in the life of patients. And I remember that many, many years ago, and some of you might have heard this, so I'm sorry for repeating myself. But many, many years ago, when I started this business, working in epilepsy and becoming a consultant with an interest, a patient of mine told me, "You're trying to sell me a drug that gives me 50% seizure reduction." He said, "Well, you know, it's like asking me to jump from the 5th floor of the building instead of the 10th floor." And this is really what it is. At the end of the day, a 50% seizure reduction will not improve the quality of life of the person. So it's okay for the FDA, but it's not really okay for us when we see the patient and for the person with epilepsy. We should always have a very low threshold for side effects, because I think that even subtle side effects can have an impact. And as Sanjay said today, many of these side effects, they're not predictable, but they probably, in the future, there will be ways that we can actually also predict all main side effects, if not all, from each drug. So we can make sure that we actually avoid exposing someone to a drug that will cause problems. We should try to give the person that we're treating a normal lifestyle as the earliest opportunity. And we often fail in here. And I think we fail in here because we cannot control seizure for some people. There are other problems. Sometimes people will have lost out on education, and they will have other things that will impact in their life. And to me, more and more and more, and I think that it's very important that we talk about this, when we treat people with epilepsy, we should try to reduce the high morbidity and the high premature mortality. So avoidable death is something we should avoid. We should really try to give people the best chance to have a fulfilled life. Now, this is really something that probably would be better at a homeopathic conference, because this is very few therapeutic areas have so many drugs. And if you're going to count, there's going to be more than 25. This is what we have. And despite all this, we still have people that continue to have seizures. Indeed, 20 to 30% of people, at least, they do not respond to this collection of drugs we have. Yes, for some people, they really make a big difference. And they're very gratifying when they work. But for the great majority of people that are still having seizures, these drugs have not really made a big difference. And indeed, when I started in epilepsy, well, a long time ago, 30 years ago, we were talking about up to a third of people that are refractory to the current drugs. And despite all these new drugs, we have not really seen a drop on that. We're still having similar numbers. And this is an indictment of the way we do or the way we treat. And it's an indictment of our lack of knowledge. It's not because we don't want to, but we don't understand often how drugs work. We don't understand the nuances of the genetic blueprints of that specific person. So we really need to move on. And this is where I hope that in 30 years' time, this will be past history. Now, why do we need new drugs? And this is a question people ask me. I get loads of emails from people asking me when there's a new drug out. You all probably heard about the cannabinoids, which are really very high flying in the social media. We heard about this every day. I'm going to say something at the end. So we still need new drugs. Well, we need new drugs to reduce people having seizures and stop seizures. That's very important. But we also need drugs that will help us to reduce morbidity and this terrible premature mortality, which is one of the biggest burdens of epilepsy. And we need drugs that are going to be better, We need drugs that are going to be more cost-effective. You know, at the moment, a new drug comes out and seems to be much higher price than the previous one. You can understand sometimes what has happened, but you know, when society becomes more and more faced with, you know, the cost of health, this becomes an issue, and we need to find ways that we can develop drugs that will be cheaper, and they can reach and they can come to everyone. So what Sanjay said earlier, for instance, if we find a drug that is already out there that could help some people with epilepsy, that would save a lot of money in the drug development. But we need to have the regulators to follow and have mechanisms in place that will allow this. But what really I think that we need to be looking is the change of the paradigm. What this is drugs that really affect the epileptogenesis, they affect the process of epilepsy and not just controlling the seizures, which is what our drugs do. And for us to get there, we need to move out of the paradigm we have now with the developments that genomics and then, you know, the science and research that's bringing, so we can really target the right drug at the right person at the right time at the earliest opportunity. So no one will be wasting time, so no one would be having a lot of frustrations in life. And of course, I would feel much more like a scientist, a clinician, rather than the shaman or witch doctor that at times I feel myself when I have to put my hands up and say, yes, it's trial and error, I'm afraid. So, what do we have in the current drug paradigm? How do we treat epilepsy? Well, don't get me wrong, we have a very rational approach to the treatment, but we don't have rational treatment. And we try, when we shoot in the dark, to control the seizures. We try to stop the seizures, but we're not stopping the epileptic process. The epileptic process often we don't not fully understand, and it might well be that the epileptic process might be quite individual, rather than being one process that will affect everyone. So there might be a very, very big level of individuality in this, which we need to understand. And again, I cannot stop saying this, the genomic work, the revolution that this will bring will let us to understand this better. So we really need a treatment that will be disease-modifying, will be curative, rather than just controlling the seizures. This is like similar is that someone has anemia, which is another simple complex like epilepsy. And we just treat iron deficiency, but without actually dealing with what is causing the iron deficiency. For instance, someone is bleeding, or someone in some countries of the world, they will have loads of worms going through their blood. So without dealing with this, yes, we can treat it, but we're just treating the symptom. We're not treating what is the cause. And here where the frustration comes in. Because I cannot say when I see someone, and most of the time, 95% of the time, I have to say, well, yes, you have epilepsy. In my experience, for the type of epilepsy you have, this drug is better than that one, but it could be the other one. So we have to sort of, it's not like I say for you, because you have this specific problem in your brain cells, we have this drug that does exactly this, so we could have a tailored treatment for that person. And by the way, we know we can use it because it's not going to cause you side effects. This is really what we are hoping. But at the moment we have is very much decreasing returns when we treat someone with epilepsy. Going back to anemia is like treating anemia blindly with the first drug, let's say iron sulfate. You would make 50% people better regardless of what's causing the anemia. And then if that doesn't work, you say, okay, let's try B12. You make another third of people probably better depending on where you are. Then it didn't work, or you've been in South America, you've been to Africa, maybe we should give you an anti-helmintic. You know, we would eventually improve the life of many people, but we would have done this blindly. In epilepsy, what we have is a very similar thing. Unfortunately, we don't fully understand epilepsy. So what we do is we try the first drug, it works in 50% of the time, And it doesn't seem to make difference which drug you use. The outcome in population terms is the same. This is telling us something. And I cannot help myself saying, hey, if I try herbal tea, would it have the same results for some people? And it might well be. So we need to understand. But it doesn't mean to say that I would say to this person we shouldn't treat, because this person might have a very benign epileptic condition, disease, problem, but the seizures are not benign. You might have a benign condition, but if you are in the wrong place at the wrong time, you have a seizure, it could come to harm. So even if they have a benign condition, I think it's important to consider the treatment, if you remember, to reduce the morbidity. So this is all what we need to understand, because we might have been having very different conversations with the people that come to see us with epilepsy. But we know from a number of studies, and this has been replicated in different ways, that if you fail 3 drugs, the chance of the 4th or 5th or 6th drug working is very small. It's less than 5%. That's 1 in 20 of the people that come, the drug will work in general terms. There are some drugs that do a little bit better, some drugs that do a little bit less, and sometimes some new drugs that we have, the only surprise is when they work. So I think it's very important that we keep that in mind, because this is responsible for a lot of the frustrations that I get from people sitting in front of me, but it's as frustrating for me because my job is to stop people having epilepsy to get their life better. So this is why we cannot deliver every time, first time around. Now, when we treat people with epilepsy, and when we see someone coming to us with epilepsy, it is always important to question, is this really epilepsy? And the reason for this is that there's a lot of misdiagnosis out there. And people that start having the first seizure, faint, syncope is a very common mimicker of seizures. And I'm afraid to say that people, when they have a faint or a syncope, they have not read the book, because they shouldn't get wet, they should not jerk, they should not bite their tongue, but a number of people do that. So you can see the confusion. And of course, if you go to see the doctor, having just seen your little kid or your partner or your friend or someone having a convulsion, this is quite terrible if you have seen this for the first time. So the picture you will pass on to the doctor and A&E, to the paramedics, it's going to be very jaundiced. And, maybe a week later you might get a more, let's say, a less jaundiced picture, and you can get a diagnosis right. So it's very important that we really go an extra mile to make sure that we got a diagnostic right. And what I say is, listen, they might be in the best interest that we don't come to diagnosis in this situation. Let time decide. And if nothing ever happens, so be it. This is the important outcome for the person. So we should not be jumping in a diagnosis, and we must always make sure that the diagnosis is correct. And for instance, chronic epilepsy is our consistent experience at Chalfont, at Gowers, our treatment unit, that 1 in 5 of people that are referred to us with epilepsy, chronic epilepsy, they don't have it. They have another condition, sometimes psychological, sometimes could be a cardiac problem, where, the diagnosis and the treatment is different. So you could say, hey, not surprising the antiepileptic drug is not working because this is not epilepsy. So this is a very important issue. We need to get a diagnosis right, and we need to question the diagnosis at every point, because things may change. Someone might be having seizures well controlled, and then something goes wrong. Maybe there's other issues behind this. Maybe this is something else now. Maybe there is a lesion somewhere growing. That's all sorts of things. So the process of diagnostic is dynamic. We need to review it every time. And this is why the NICE guidelines recommend that every person with epilepsy is seen by a neurologist or a specialist once a year, at least. But does that happen? And we heard already that there are, quite a lot of discrepancy around the country, and probably less than 50% of people that have epilepsy, well controlled otherwise, they're seen in hospital. They're just often seen at primary care by GPs. Now, if the first mantra we have when we treat epilepsy is this epilepsy? I think more and more we're getting into a second mantra. This is Is it epilepsy? Yes, I'm happy, but epilepsy and what else? And why is this? Because people with epilepsy, they often will have other health problems, which, when we are neurologists, we're sitting there and say, oh, you have another problem, sorry. Go and talk to the GP, and they will have to refer you to the gastroenterologist, they will refer you here and there. But this is not really, and we sort of miss, often dealing with the comorbidities will help epilepsy control. An example for this is, for instance, a person has diabetes that is not well controlled, and that might have an impact on the seizure control. Someone has sleep apnea, and they don't sleep, they don't have refreshing sleep, and that will have an impact in seizure control. So we need to really ask what else is going on, because trying to deal with the comorbidities that go with the epilepsy, they might be an important part of our treatment and our management. The implication from practice here, I think, is that we need to move on for clinical assessments that are just about seizure control. We need to really try to ask and address and be proactive in getting often other medical agencies, primary care, other hospital doctors to have a more joint approach to people with epilepsy. And as I said, having epilepsy should really increase the suspicion of other problems. And, you don't know when the seizures are going to happen. You're going to be very anxious if you go out. God, a seizure could happen. And this will bring anxiety, which over time may become chronified. People, they were doing a job, develop epilepsy, and then told, oh, you cannot do this anymore. Not just the seizures, but their life change. That could have an impact on for instance, make people depressed. So we need to always be very proactive and trying to identify these comorbidities and take care of them as well. Now, when we look at clinical scenarios to start someone with epilepsy, we have newly diagnosed epilepsy. That's when we're going to be friends of the person, because we can actually deal with 70% of people that develop epilepsy with the first or second drug. They think I'm very good, and we're going to be friends. But if the first or the second drug doesn't work, we have a problem, because then it becomes very frustrating, and over time people will go into what's called chronic epilepsy. But I think that it has very many names, and the latest I have been hearing in some parts of the country is brittle epilepsy, refractory epilepsy, drug-resistant epilepsy, all sorts of names, but that basically means we have not been able to control this person's epilepsy. But chronic epilepsy, how do we define it? What does it mean? We could have a whole day here discussing, and if we have quite a number of neurologists and pediatricians, we wouldn't agree. But we know that someone that has not responded to the first drugs, they are more likely to become chronic. If someone has actually had a long time before we could do something, decrease the seizure, that's a bad mark. And someone that has a lot of seizures early when they start having, that is also a bad prognostic for the way that we do it. But we need to always remember what I said earlier, that a number of people that have the label of chronic epilepsy, they don't have chronic epilepsy. And often because they don't have epilepsy. So how can they be said, you have chronic epilepsy when epilepsy is not a problem? Then there's this sort of situation that there are people out there that have some, what we tend to call genetic epilepsies, because that's well known for a while, that they don't do well on some drugs. A typical example would be a person that has juvenile myoclonic epilepsy. And if they are exposed to drugs from a family that we call sodium channel blockers, they tend to get worse. So if someone comes and someone has one of these drugs at the background and other drugs are tried on top, things are not getting better because they have an offending drug there. So sometimes taking that drug off could make a difference. So that's responsible as well for a number of people that have chronic epilepsy, is because they don't have the right drug for that sort of type of syndrome. And then the latest, or the sort of one thing that we can do things about, is people not taking the drugs. And I think that this is very common. Sanjay already alluded to this, but there's been a number of studies that show that people forget to take the tablets. And it's very easy. Have you, any one of you having to take drugs, have you ever been able to say that I never forgot once to take a drug? That doesn't exist, not in my experience. What happened is that doctors tend to be very prescriptive. They tell the patient, you need to take this. Someone forgets, do you think he will tell the doctor? I'm going to be told off. So people, they don't tell the doctor, and then this becomes, then you increase the dose again because it's not working. And, at the end of the day, this becomes a mess. So it's very important that we establish a partnership with the person. And we need to have an understanding, yes, you forgot to take the tablets, we can talk about it. Because no one will ever be able to say, I never forgot to take my tablets, particularly the doctors. So it's very important that we actually remember the reasons for chronicity, which I call not really reasons for this. So when we see someone nowadays, it's very important we review the history of epilepsy. We understand how the diagnosis was done. We go an extra mile to find someone that has actually seen a seizure. So that will often give us clues what type of epilepsy, where it's coming from. And nowadays, most people carry around the best tool for the diagnosis of epilepsy. Do you know what that is? It's not an EEG, not an MRI. It's a mobile phone. Because, often if you come and you have a clip of a seizure, you can go a long way to try to understand what's the next step, and sometimes it can save a lot of treatment. And I had a gentleman that had some problems. He had been diagnosed non-epileptic attack elsewhere. We wrote to him when he was coming to say, could you bring some clips? He got his friends and colleagues and siblings to clip. He brought 6 or 7 clips of a very nice. As soon as I saw it, I said, this cannot be anything else but a frontal lobe seizure arising from the left side. So the diagnosis was made, we could start the treatment, and we saved NHS, investigations in terms, of course we still did, but we didn't actually have to wait. And this person has never had a seizure since. But to some extent, he missed 4 years of his life because all these problems about the diagnosis, because his seizure was not typical for what often a GP or someone will think it's a seizure, because not all seizures are the same. So it's very important that we always try to confirm the diagnosis of epilepsy. We classify, but we also try to find out what else is going on with this person in terms of comorbidities. And we should always try to establish what is behind the epilepsy. You would not accept someone saying you have anemia, Mr. Smith. You want to know why this person has anemia. And of course, there are situations that our technology has not yet advanced, so we can give a precise diagnostic. Hopefully, when we have the whole genomic out, this might be much less. But nowadays, for people with focal seizures, for instance, with the right imaging scan, we probably can find something in 60 to 70, sometimes even more if you use some other techniques. So we need to try and find out what's the risk factor, what's behind this person's epilepsy. And we should always talking very openly with the people about their taking the tablets. Because this is an issue, as I said, that can have a big implication. And we should always try to have a very clear plan. It's very important that we have a plan, we see a person, we make a plan. We go over, which drug have you used? Why have you come off this drug? Why you couldn't take this? Oh, you didn't take this drug. But it's also often important to try to find the source. Some person's medical records, because people cannot remember. A person might say, oh yes, there was a blue tablet I took, was no good, but what was this? So we need to really try to find out what it is, because sometimes we can identify a good drug that was not used properly. A common example is that sometimes doctors tend to scare patients about rashes. Rashes are terrible, they can cause terrible problems. But if I ask you here now, how many of you had a rash this week? I'm not going to do this, don't worry. But I would be surprised if anyone wouldn't put their hands up if they've been truthful, because we have rashes all the time. So when the doctor tells a patient they need to be alert for the risk of a rash, this can be misinterpreted. And there have been some studies, not in epilepsy, in other areas, that suggest that up to 70-80% of times people come off drugs because of drug rush. The rush is nothing to do with the drug. So it's very important that we try to identify how each drug was started and written off. And we should then try to work out and have a very clear plan. This plan needs to be centered at the person. We need to understand what are the persons, what they would be comfortable. And I tend to discuss with people which drug should we try next. And people may have different views of what we have, but we need to give and provide the information. And we should always have regular review. And I think that having a clear plan is important because often, a doctor might be on holidays or the physician might be somewhere else. There might be a registrar coming in. If you don't have a plan, it ends up in an ad hoc treatment. But, people get very frustrated. Oh, I have to go through my history again. Why asking this? Can he or she not just read what is in the notes? And it's very important that we have a very clear plan because that will, again, we might not be helping, but we know where we're going and we know what we are trying to do. Choice of treatment. Well, I'm afraid to say that we don't have any evidence that would tell this drug is, at the current time, the drug for this person. We can say, for this type of syndrome or seizure type, this drug is better than others. But in no situation we have 100% of certainty. And this is, again, a problem. And even if we think the drug is going to work, we don't know if this person is going to have side effects. And some of the side effects, at the moment, they are unpredictable, although, again, pharmacogenomics is making progress. And we know, for instance, what are the genetic markers for some severe side effects in some ethnic groups. But, we would like to understand and have this for all people, not just a particular ethnic group. So we want to move to the state we have a database, we can interrogate, and we can ensure that we don't actually expose a person to the risk of a drug that can cause them problems. So it's very, very important. At the moment, we tend to choose drugs for the person. I tend to discuss this with the person. Of course, if something doesn't go right and goes wrong, we already have a plan B, but the person understands that was always the things, and that we cannot say, hey, this drug is going to be for you and it's going to work, because we don't have a crystal ball. It is trial and error at the end of the day. The question, older and new drugs. Well, older drugs are well known. They're devils we know. They're poisons we know. And they tend to be a little bit more predictable than some of the new drugs. Not because they're more predictable, it's because we have more experience with the older drugs. This is sort of, so I tend to know a little bit. But a drug just comes out. It might take a time for us to identify any rare side effects. And a good example is a drug that came out, and it's responsible for a lot of I was just made a consultant when this drug was withdrawn. And basically, this drug causes a rare side effects in 1 in 3,000 people. And when the drug was developed, it was 1,800 people had been exposed to it. So this rare side effect didn't come out. When the drug was launched, the side effect came out. And until people picked up this, it led to 31 fatalities in the US and 3 in Europe. So there were 34 people that died as a result of a side effect of a drug that did work for some people. This drug is not around anymore. But, you could say, hey, if we knew this, if we had the test, if Professor Sisodia had the European money to develop this, he had this, he could then, screen people, the ones at risk, and then he could, make sure that no one would have harm as a result of this drug. And this is, this is what I say predictable, and this is where we have to improve. There is this belief among some people that new drugs are better than the olders. I don't think there is evidence. Some older drugs might be better for some people than new ones. The problem is some of the older drugs, we know the chronic side effects, which often we don't know for the new drugs. So what I always say is the best fit for the person, and always make a clear assessment of the risk and benefit that this drug could have, and discuss this with the person, and you can take a joint decision on this. These are the new drugs. I'm sure that you will know some of them. The ones in red are the ones that went, I think that the ones that actually cause a lot of problems. Progabide was the first new drug to come out almost 30 years ago, and it caused a number of people died as a result of liver failure. We had vigabatrin. A number of people had problems with their vision. It's not used widely. We had felbamate, the drug that I mentioned. And recently we had a drug, that retigabine, which had a chronic side effect, making people's extremities go blue. Apparently Chelsea had a stake in the drugs, but not quite sure if it's true. And we have just now, 2-3 weeks ago, we had the launch of brivitiracetam, which is sort of, depending on who you hear, an enhanced, but it's levetiracetam with an hum, as someone told me. There are loads of drugs in the pipeline under the old paradigm where we're shooting in the dark and hoping it will work. The one that had the most attention, and we get this question often in clinic and you get emails, is the cannabidiol, which is a drug that is derived from cannabis. It's not the delta-carabinol, which is the active substance, which some people come and say, can I have it? But it is actually another chemical that comes from this plant, and it got a lot of exposure in the social media. A lot of people are coming and trying and wanting to have it. And I think that there is a risk of people being frustrated or being very disappointed, because it's coming with very high expectations. And as I said, often driven by even the FDA. The politicians were making such a campaign, writing emails, Facebook, everywhere, Instagram, talking about this, that this drug was actually licensed without, as an orphan drug for some conditions. And the trials are coming out now, and it's not really as magic bullet as some people believed. And indeed, there's been a recent open study. I don't believe an open study in this situation is not the right approach, but that suggested that about half of the people had a seizure reduction, a third got more seizures, and 2/3 had side effects. That's not really what I would expect of a magic bullet or the magic bullet that we hear and that we get bombarded in the media. So it's very important that we understand this, and I think that we need to wait for the randomized controlled trials. And I believe that there will be a niche for this drug. And the niche probably will come from Professor Sisodia's studies, probably identifying someone that has something on the cannabidiol receptor, and there might be some people that will respond to this. So, it might have a use, but at the moment I don't think it's going to be a magic bullet in terms of new drugs, and I mentioned at the beginning we need them. What I think is going to be the real way to go forward is more and more in terms of pharmacogenetics, understanding where this drug fits in, but we need to understand better the genetic architecture of epilepsy. So we will really go to the new treatment paradigm of precision, tailor-made drugs for this person. I was also asked to talk about the misuse of drugs. I don't know how I'm getting on with time. You Caribbean? I'm Brazilian, remember, so we also tend to run late. But
give you a few more minutes, and then we should maybe have 5 minutes from the floor. But we're approaching lunchtime.
I'm just getting to an end, don't worry. So we need to make sure that we don't misuse drugs. And often one of the common things I see in clinic is people some of our colleagues out there having a sort of overzealous, sometimes unthinking adherence to drug levels. And as a result of this, you might have situations where people will treat the results rather than treating the person. That's very important that we keep that in mind. And it's also very important that often we may ignore a modality of treatment. Epilepsy surgery at the moment is a very effective treatment for a small group of people. But if someone is a candidate for surgery, we should be discussing and addressing this at the earliest opportunity. So we need, and I think that sometimes if we keep changing drugs without thinking about this, that's a misuse of drugs. Stopping drugs, it's a very important question because people are put on drugs and people want to know when they can come off. And I think that, yes, we should always consider to come off, but it needs to be very much tailored and the person's requirements. We know, for instance, that there are markers for a bad outcome if people come off drugs. So we can actually discuss with the person, but we can never give them 100% certainty that the seizures are not going to come back. That's very important. But we need to discuss this with the person. For instance, are you prepared to take a risk of 20% of seizures coming back? You might not be able to drive after this for a while, so what do you want to do? And people need to understand that. And I think that, yes, we should consider that. Yes, there is a time, but we need to also make sure that the person is on the plan, and we should always try to do it on a sort of discuss and then agreed, and we have a clear schedule, rather than someone just stop the drugs overnight, because that probably increases the risk of more seizures. And that's my last, maybe a conclusion slide. Now, I said this in the beginning, we hear this in different ways here today. We need to have a holistic approach to the treatment of epilepsy. And we need to really listen to the person. We need to take their agenda into account. We need to provide continuity of care. And this is very important. And to conclude, with the current flawed treatment paradigm, we can make up to 70% people seizure-free. Antiepileptic drugs are still the mainstay of treatment. But we should always remember that, it's not going to be 100%. It is trial and error. And it's very frustrating to our parties that we cannot tell people at the beginning what will happen. So the way I see the future is really through what we heard here before the coffee break. Is that genomic will make a big difference. But it's a challenge. We need to get everything in place. We need to understand things. We need to build databases that will allow us. But I'm still hoping that before I retire, I will be able to be a real physician and treating people with the right drug at the right time, and we will all be friends forever. Thank you very much.